I'd like to introduce Dr. Leslie Hayes. She's a family physician at El Centro Family Health, and she provides full spectrum outpatient care. Since the beginning of the COVID epidemic, she's served as the primary care preceptor for the COVID ECHO program through the University of New Mexico. And a fun fact about her is that although she considers herself the most unromantic person in the world, she said 27 years ago, she walked into a party, saw a man, and immediately decided that. So even though she says she's still completely unromantic, that one lapse got her into a long-term relationship with a man who would love to be romantic, she said, and buy her chocolates and flowers, but she could care less. So thank you, Dr. Hayes.
All right, I am going to be talking about long-haul COVID in the pediatric population. And I'm just going to preface this with saying this was the hardest talk I have ever written. It turns out I agreed to do this, and I have dealt a lot with long-haul COVID, and I've dealt a lot with the pediatric population. It turns out there's really no literature at all on long-haul COVID in the pediatric population. So I did my best, and I'm really going to try very hard to let you know when I'm talking about stuff where there's actually data versus when I'm just kind of making it up. So, and again, there's not great data. I've done my best to look at all the available literature. I've ended up citing some studies that really I would not normally cite because they're not great studies. For other topics such as treatment, there was really no evidence at all, and not even necessarily an expert consensus. And I'm going to do my best to talk about what we do actually know for sure and which studies are best and which recommendations are based on actual data. So learning objective, understand common presentations of long COVID in the pediatric population, be familiar with the workup for long COVID, and be familiar with the treatment. And the way getting educational credits work is you have to do it several months in advance. So I came up with those goals before I realized there wasn't actually information on it. So I may focus a little bit on some other stuff here. And I just wanted to mention acute COVID real quick in children and teens. In general, it's a lot milder in children than adults. And a substantial proportion of the kids who get COVID actually have asymptomatic infection. And the vast majority of children with mild or moderate disease can be managed with supportive care. When children do have symptoms, the symptoms are generally similar to what adults get: nausea and vomiting, fever, cough, shortness of breath, upper respiratory symptoms. And when they're doing surveillance testing pre-procedure, what they found is about 45% of the kids who had a COVID infection actually had no symptoms at all. So they think a good percentage of kids who get COVID do not have symptoms from it. And there's not a lot of study of therapeutics. Most of the recommendations have been extrapolated from adults, and I'm going to be doing that a lot. And if anyone out here actually takes care of kids, you really don't want to extrapolate from adults if at all possible. That's where all the research has been done. So risk factors for severe COVID among hospitalized children, 2 or less, include chronic lung disease, neurologic disorders, cardiovascular disease, prematurity, airway abnormalities. From 2 to 17, feeding tubes, dependence, diabetes, and obesity are the main risk factors for severe COVID. And severe COVID is also much higher among Hispanic children and non-Hispanic Black children than it is among white children. Overall, the risk of severe COVID was about 12 per 100,000, so thankfully quite rare. So long COVID definition, and this is one of the problems with long COVID, is that there are not actually good definitions. And so because of that, especially a lot of the early studies, since they didn't have a definition, they looked at a lot of different things and not necessarily the same thing from study to study. So first off, here's all the various names for long COVID. The official name is PASC, or post-acute sequelae of COVID. That's kind of unpleasant to say, and it's too long, so almost nobody uses PASC. Other names I found were long COVID, long haul COVID, prolonged COVID, post-COVID syndrome, long-term effects of COVID, and chronic COVID. So the clinical definition of post-COVID-19 from the World Health Organization And this did not specify whether or not it included children or not, but I think it's generally a good definition and it certainly applies to children. Post-COVID-19 condition occurs in an individual with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. Common symptoms include fatigue, shortness of breath, cognitive dysfunction, but there are others. They generally have an impact on everyday functioning. Symptoms may be new onset following initial recovery from an acute COVID-19 episode, or you may have symptoms that just persist from the initial illness. Symptoms may also fluctuate or relapse over time. And the only organization I found that actually had a good definition of pediatric long COVID actually came out this year. It's from the Italian Inter-Society Consensus on Management of Long COVID. And if anybody's actually interested, this was probably the best article I read about it, and I would encourage you to look at this one. So the way they defined long COVID is a clinical condition that includes all pathological manifestations following the acute phase of SARS-CoV-2 infection and which cannot be attributed to causes other than SARS-CoV-2. Although it is not currently possible to precisely define the type and time limits of these manifestations, long COVID can be considered after 3 months from the diagnosis of SARS-CoV-2 infection in the presence of symptoms that last for at least 2 months and which cannot be explained by another diagnosis. And they said what I found really to be true, that the true prevalence of long COVID in pediatrics is not exactly determined. It seems appropriate to recommend evaluating the presence of symptoms suggestive of long COVID near the end of the acute phase of the disease between 4 and 12 weeks. And long COVID should be suspected in the presence of persistent headache and fatigue, sleep disturbance, difficulty concentrating, abdominal pain, myalgia, arthralgia. You can also get persistent chest pain, stomach pain, diarrhea, heart palpitations, and skin lesions. May possibly be symptoms of long COVID. And I just want to real quick distinguish long COVID from multisystem inflammatory syndrome of children. These are both caused by COVID. In both, we think there's possibly dysfunction in the immune system that is causing them. They don't know for sure the cause of either of them. However, MISC is quite well defined and much more of a medical emergency than long COVID is. So case definition, and this has been around since, I believe, like October of 2020. It was definitely during the first year of the pandemic. So MISC is defined as any individual less than 21. They need to have fever, laboratory evidence of inflammation, and evidence of clinically severe illness that's severe enough to require hospitalization. Long COVID is something that you kind of see and wonder if that's what's going on. MISC is a medical emergency. You get them to a pediatric hospital right away because these folks are going to need care. They need to have multi-system organ involvement, cardiac, renal, respiratory, hematologic, GI, dermatologic, or neuro. There needs to be no alternative plausible diagnosis. And they need to either have had a recent SARS-CoV-2 infection by PCR or rapid antigen, or COVID exposure, or I have definitely seen kids diagnosed on serology as well. And they need to have fever of over 38 degrees for 24 hours, or report of a subjective fever lasting more than 24 hours. And they need to have evidence of inflammation, including elevated CRP, or erythrosedimentation rate, fibrinogen, procalcitonin, D-dimer, ferritin, lactic acid dehydrogenated, or interleukin-6, elevated neutrophils, reduced lymphocytes, low albumin. All right, prevalence of long COVID. Dang, it was working so well too. So there's a real problem as far as determining prevalence. First is, as I mentioned, there's been a lack of an exact case definition. So different studies, because they use different definitions, have had a different case prevalence of it. There's also a lack of consensus. How much time do you have to let elapse for the symptoms to be considered long COVID? Some people say they need to persist at least 4 weeks. Some people say at least 12 weeks. That's going to give you a difference in prevalence. The early studies that they did on this were actually quite small. They often didn't have any data on pre-existing medical conditions. So somebody who had asthma before might get counted as long COVID because they're still complaining of shortness of breath at 12 weeks, but they had shortness of breath a year before as well. There's often a lack of a control group for many of the studies, which was really quite a problem. And then the other thing is many of these studies, what they did is they sent out questionnaires to a bunch of parents of kids who had had COVID and said, hey, what kind of symptoms does your kid have? And the thought was that parents who had children with symptoms might be more likely to respond to this. And they think this is actually true both for kids with COVID and kids without, because they're like, oh, my kid still has a headache. I probably should fill out this questionnaire. So there's significant issues with almost all of the studies. And this is my favorite part of this entire talk. Various studies suggested a prevalence anywhere from 0% to 80%. Yesterday, the guy talking about ADHD was laughing about the prevalence of ADHD is considered somewhere between 5 and 9%. And he said, what a huge, difference that was. Well, I have 0 to 80%. This is why your crazy uncle thinks COVID is a hoax. He points to stuff like this. He's like, you guys can't agree on anything. COVID clearly doesn't exist. So the first study suggesting that there was long COVID in children was a study from Italy. And they suggested that the prevalence of long COVID was 66% if you looked 2 to 4 months out, and 51% over 120 days after infection. A Swedish study done around that same time said that 22% of children who had been hospitalized had persistent symptoms. Fatigue was the most common, found in 8 of the 12 patients in this study. However, once they started doing controlled studies, these were actually much more reassuring. So the highest rate I found in a controlled study was found in an English study of adolescents. And there they found that 66% of COVID positive patients and 53% of COVID negative controls still had symptoms at 3 months. So that's a difference of 13%, which is a substantial difference. But a few things on this study. The first is the studies looked only at adolescents, and there were a lot more female than male patients. And we'll get a little bit later into who are the groups who are most likely to have long COVID, and it's both adolescents and females. So this is by definition a group that is going to have a little bit higher incidence of long COVID. Interestingly, the rate of symptoms was higher at 3 months than it was at baseline when they were actually diagnosed with COVID. So I don't know quite what to make about that. And then again, the response rate was only 13.5%. It was roughly equivalent for both COVID positive and COVID negative adolescents, but that's a really low response rate. And if only the people who are symptomatic are responding, you're going to get a lot higher percentage. So keep that in mind about all of these studies I'm talking about. Then a study from the United Kingdom showed that persistent symptoms are found in 1.7% of all children and 4.6% of children with a history of SARS-CoV-2 infection. So again, symptoms are more common in the children with SARS-CoV-2, but not by a huge amount. And then a Swiss study found that 4% of seropositive children and 2% of seronegative children had persistent symptoms lasting more than 12 weeks. So it does seem that there are probably some children out there who do have persistent symptoms after COVID. So this was actually probably the best study that I found. And even their response rate wasn't great. The response rate for children with SARS-CoV-2 was about 44.9%. Response rate for controls was 21.3%. This was a study of Danish children aged 0 to 7. And they asked who still had symptoms lasting more than 4 weeks. And they found that symptoms were very common both among children who had had COVID and among controls. Children who had had SARS-CoV-2 between 6 to 17 reported more symptoms 4 weeks or more out than the controls did. And it wasn't a huge difference, 28% versus 27.2. Probability of 0.02, so it was statistically significant, but tiny difference. This was really not a huge difference between the two groups. Interestingly, children in the control group, age 0 to 5, reported symptoms more frequently than children who had actually had COVID. I think this is probably, as I said, selection bias, because there's no way I can believe that, COVID made you less likely to have symptoms 4 weeks down the road. So this was my favorite one. So this was a meta-analysis, and they looked at all of the studies of COVID, long COVID in pediatrics. And what they found, if you look at the bottom are the studies that did not have a control group. And these found rates of 13%, 58%, 24%, 30%, 22%. However, if you look at the top group, these all had a control group. And as I mentioned, the highest was in the British study that was 13%. And then otherwise it's 1 to 2%. So they think a lot of the things that we were actually calling long COVID are really just pandemic effects on the kids. So there is definitely, I think, some effect of COVID on children, but even that I can't be sure from the studies, because like I said, I have yet to see a study that I was just like, oh, this is such a robust, good study. So this is from that meta-analysis, and I thought they phrased it much better than I ever could. In the absence of a control group, it is impossible to distinguish symptoms of long COVID from symptoms attributable to the pandemic, such as lockdown measures, school closures, deprivation of seeing friends or being unable to do sports and other activities, or seeing family and friends suffering or even dying from COVID. The results from the studies to date suggest that infection-associated symptoms are not necessarily more common or severe than pandemic-associated symptoms. And pretty much all of the controlled studies showed this, because there were really high rates of symptoms even in the kids who had not had COVID. So risk factors for COVID in pediatric population. The following groups have had more long COVID symptoms. As they get older, adolescents are much more likely than school-age children than toddlers to have long COVID. Girls are more likely than boys. Allergic disease prior to having COVID makes you more likely to have long COVID symptoms. And kids who were sicker before they got COVID are more likely to have long COVID symptoms. And these are also, if you can remember back when I was talking about acute COVID, these are also the kids who are more likely to have severe disease, as the kids who had worse pre-COVID health. And so it's not surprising that they were more likely to get long COVID. So common presentations of long COVID. And this is actually a diagram about adults. And I'm just going to say, when kids do get long COVID, they seem to get the same symptoms that adults do, just in different prevalence. But I just thought it was a nice diagram. Cognitive impairments, fatigue, dyspnea are generally the most common symptoms, both in pediatric and adults. And just like I said, this diagram is for adults. Symptoms for children are similar. Frequency is a little bit different. The most frequent symptom in most studies was tiredness or fatigue. It showed a 6% prevalence in seropositive children versus 4% in seronegative children in the UK study. For preschool children, risk difference was 0.05, and for school-age children, it was roughly the same. There was one UK study that found no difference in fatigue between the positives and negatives. Some of the other things that some of the studies found were difficulty concentrating, 3% versus 1%, an increased need for sleep, 2% versus 0%, loss of smell, loss of taste, headache, and ENT symptoms were common. And this is such a complicated graph, and it doesn't have all the information that I would have liked. But this is from the Borch study that I said was the best one. And if you look, what this shows, the more purple is something that was pretty much the same between COVID positive and COVID negative, whereas the closer it gets to yellow, it was more common in one than the other. So the ones up here, the headache and loss of taste and smell and fatigue are more common, especially in adolescents. Interestingly, concentration problems were worse in kids who had not had COVID, which I don't know what to make of that. So, but fatigue does seem to be very commonly associated in loss of taste or smell. Certainly, we know has been pretty pathognomonic for COVID during the entire epidemic. And then this is just the same thing in graph form for those of you who prefer graphs. Hang on, I gotta get glasses on because I need to see these. So respiratory problems are more common in 0 to 17 who have had COVID. Muscle pain, loss of taste, fatigue, dizziness, and chest pain. All of these were found to be statistically a little bit more significant or a little bit more prevalent in children who had had COVID. And then for kids 0 to 5, there wasn't a lot that was much more common, a little bit more muscle pain and loss of taste, and then fatigue a little bit more common. Interestingly, cough was more common in kids who had not had COVID. And for kids 6 to 17, as you can see, there is a little bit more difference. Muscle pain, loss of taste, fatigue, dizziness more common in children who had had COVID. Interestingly, this one found nothing on loss of smell here. So the one other thing that they found, and this was pretty consistent across a lot of the studies, is that children and teens who had had COVID were more likely to have multiple symptoms. Children who had not had COVID were just as likely to have 1 or 2 symptoms, but children who had had COVID, 29% of them in a study in England of positives and 19% of negatives had multiple symptoms. So that was just something I thought was interesting. And same thing in this Danish study was that 34% of children who had had COVID reported 1 symptom, 28% reported 2 symptoms, and 36% reported 3 symptoms. Children who had not had COVID, 54% reported 1 symptom, 23% 2 symptoms, and only 22% reported 3 or more symptoms. So they were a little bit more likely to have a lot of different symptoms. But most of them still rated themselves in good or excellent health. 41% of the seropositive and the seronegative said they were in good health. And 53% of the seropositive and 55% of the seronegative said that they had good health. The other thing is mental health issues are super common with the COVID pandemic. These do not appear worse for adolescents or children, regardless of whether they tested positive or negative. So in this group, they contacted over 50,000 adolescents and 23,000 who were positive, 27,000 who were negative, and they got about 3,000 of both who completed a questionnaire. Again, low numbers, 13%, but they found no difference in the mental health scores for either COVID positive or COVID negative. The other thing, and I think this is really important, is we don't know the expected duration of symptoms. COVID has only been here 2 years. And to me, there's a big difference if we have 1% of children with symptoms that last 3 months, or even 5% of children with symptoms that last 3 months, or if we have 1% of children who are so fatigued they can't get out of bed the rest of their life. I mean, the first, that's kind of a nuisance, but if it's 1% of kids who are going to be permanently affected by this, that I think we need to respond to a whole lot more. And we just don't know that because COVID hasn't been around long enough. And this is another one from Borch, and like I said, they could have presented their data in a way that was a little easier to read. But in this, somewhere, so oops. So in this, the green up here is kids who still had symptoms at the time of the survey, and somewhere between 25 and 40% of the kids still had symptoms. So, however, the thing is, what they didn't say on this graph, and what I wish they had, is down here at the bottom are the kids who had only were, 1 to 3 months post-COVID. Up here at the top were the kids who were over a year post-COVID. I want to know, were the green people more likely to be 4 weeks after COVID, in which case, like I said, it's less worrisome? Were all the people who were a year out asymptomatic? And they did not say that anywhere in the paper. So this study may actually have the answer, but they didn't put it in. So, and that was the only one I found that looked at duration of symptoms. So. And then the other thing I wanted to mention is POTS, or postural orthostatic tachycardia syndrome. And this is a syndrome where, and it normally occurs after upper respiratory infections, mostly in young women, that when they stand up, their heart rate goes really, really fast. They get dizzy, they feel crummy. And it is actually fairly common in COVID. However, it doesn't seem to be common in adolescents. POTS up until this time has been very common in adolescent and young adult girls or young adult women, but I could not find anything. It seems to be an older population that's being affected by COVID. All right, so this is workup of long COVID as far as from a heart standpoint. This is mostly directed at athletes. And so I'm gonna say this is more for the older adolescent. This was the only consensus or expert opinion I was able to find on working up long COVID. So, and you know, they basically, it's worth looking at this Journal of the American College of Cardiology article from this year if you want to look at, you know, if you're going to be working up people for return to play, because after they've had COVID, I think this was really useful. So some of the basic questions that they say to ask: clinical presentation of the acute infection. Are they still having symptoms such as chest pain, shortness of breath, palpitations? What symptoms are the most bothersome? And do they have any trouble with exercise? Anything else such as cognitive impairment, sleep disturbance? And are there any cardiovascular comorbidities? Did they have hypertension or a heart murmur before they got sick? Do a physical exam, and they especially recommended doing orthostatic vitals, check the blood pressure, lying, sitting, and standing, check the heart rate as well. And then check it 2, 5, and 10 minutes after they've stood. And if you have any concerns at all from the physical exam, they said consider laboratory testing such as CBC, BMP, EKG, echocardiogram, ambulatory rhythm monitor, chest x-ray, PFTs. Vast majority of kids are not going to have any of these symptoms, but if they do, you do want to work them up before you allow them to return to play. Anything that's abnormal, refer them to a cardiologist. And I'm going to skip the bottom and go to the next couple slides. So work up for other symptoms, and none of this has any evidence or any expert recommendations for the pediatric population I've been able to find. And I just did my best to extrapolate from how I would normally work up a kid with fatigue and what is recommended for slightly older age groups. So if they have shortness of breath and cough, check an oxygen saturation both at rest and have them walk around your clinic a few times, see if it drops. Check a chest x-ray. Consider checking a CAT scan of the chest if they have severe symptoms. This is going to be rare, but if they've got severe symptoms and you can't find a cause, especially if they've got a lot of shortness of breath or bad cough, I would do it. And then pulmonary function tests. Fatigue, again, check orthostatic vital signs. Ask about sleep. Sleep apnea is actually a fairly common sequelae of COVID in our adult population. So especially for older adolescents, we need to be thinking about it. And it's actually not uncommon in the pediatric population. And most pediatric patients who get sleep apnea, it's because their tonsils are enlarged. And so this is definitely worth thinking about in a kid who seems fatigued. And so I would, if you have any concern about this, send them to an ENT for evaluation of their tonsils and their adenoids. And then think about a cardiac or pulmonary workup if they really have severe fatigue and you can't figure out what's going on. And then check electrolytes, renal function, liver tests, check a glucose, make sure they didn't develop diabetes, check a CBC, check thyroid tests. As far as treatment, again, no specific recommendations for kids that I could find. And there were definitely no research on the treatment. So if you find any specific conditions such as diabetes or sleep apnea, work them up and treat them as you would normally. And then, so again, this is for adults, but especially for older adolescents, I thought this was good. So they said, look at how severe was their COVID. People who are more susceptible, female, people who had a strong immune response to COVID, people who are genetically susceptible, people who had underlying medical conditions, and then how quickly did they recover from the acute infection, their vaccination status. And so what happens is they said the early symptoms are fatigue and decreased exercise capacity, and they may be orthostatic, that they get dizzy every time they stand up. And so what happens is they just stay in bed because they don't feel well. And then they just become deconditioned and their blood volume is down and their heart isn't working as well. And so then they get this limitation in exercise capacity, decreased quality of life, they can't work or go to school. And then all of these, the fatigue, the decreased exercise capacity get worse. And so you've got to break that cycle with these kids. So if the patients have a normal workup post-COVID, including normal heart workup, or they're 3 months out from a diagnosed cardiac condition with COVID, they had myocarditis, but that's now gotten better and the cardiologist has given them the all clear. At that point, you really want to think about getting them into physical therapy because you need to break this cycle of deconditioning. And if you just send them straight back to exercise, they're probably going to wear themselves out. So you need to gradually increase their conditioning. If they're mild to moderate deconditioned, recommend gradual return to exercise. And the way I actually recommend this when I'm, someone who I've got who's fairly deconditioned is start out at something you can do. Because what I find is most people go out and they want to do, an hour of exercise that first day, and then they're worn out and they can't do it. So I tell people start out at, 5-10 minutes a day, whatever you can do, and then gradually increase it. Oops, wrong way. And the last thing I wanted to talk about is anosmia and ageusia. And anosmia is lack of smell, ageusia is lack of taste. And my husband actually has congenital anosmia, so this was something I was interested in long before the pandemic. So we've had to make some lifestyle changes because of the fact he can't smell. So neither of these are actually well studied, despite the fact that they really do have a huge effect on quality of life. And it's considered a fairly minor post-COVID symptom, but it really affects people in huge ways. So just some definitions: anosmia means you can't smell anything. Hyposmia means you have a decreased sense of smell. Parosmia is when things smell funny, and people complain about everything smells like burned rubber or like dog feces. They just smell really bad, and that's very distressing to people. Ageusia was when you can't taste anything. Hypogeusia is decreased taste, and dysgeusia is altered taste. So again, things just taste bad. And they actually said, especially initially, anosmia has kind of gone down with the more recent variants, but initially they said it was actually better as a screening test than temperature checks. So, and the mechanism for anosmia and COVID is interesting because normally what happens with an upper respiratory infection where you lose your sense of smell is you just get so much nasal congestion you can't smell. However, with COVID, it actually attacks the support cells and the stem cells around the neurons in the nose. And so you actually get damage to the support for the olfactory neurons. And COVID-related lack of taste seems to particularly affect sweet and bitter. So people can still taste sour and salty. And one problem I actually found with people with COVID-induced ageusia is that they tended to put salt on everything, and people were actually having high blood pressure as a result of this. It can be associated with weight loss and malnutrition because people just are not interested in eating. So it's really important to pay attention to colors and textures in this circumstance, because that's going to make food much more appealing for people. And food safety is important. My personal family history, my father-in-law also has congenital anosmia. And my mother-in-law was working at a job she really liked when they first got married. And he ate some bad food in the fridge because he couldn't smell it and realize it was bad. And so he insisted that she quit her job and come home and cook for him so that he didn't have to worry about that again. So you got to be careful to follow guidelines. My husband used to throw out everything the exact day it expired, and I finally got him to, can I at least check it first? So natural gas leaks can be an issue. Another family story, my father-in-law decided he was going to dig a gas well in the backyard. And when he found natural gas, apparently natural gas has no odor, you have to put a chemical into it. So you're supposed to put a couple drops, he dumped the entire bottle in. And so, everyone was convinced there was a horrible gas leak because they could smell the gas smell all over the neighborhood. So personal hygiene issues can actually cause social withdrawal. So having somebody they can check, do I smell okay? Is that okay? And caution with scented products. We've all seen that in elderly women who are applying way too much perfume because their sense of smell has just gone down. Smell training is an interesting thing. It doesn't work for complete anosmia, but it may help for hyposmia or parosmia. And there's really no data on this, but there's a lot of anecdotal evidence, and it's easy and cheap. So basically what you do is you need a smell training kit. And there's organizations such as the absent.org that I mentioned on the last slide that will send you oils. And you get essential oils. The one that they have are rose, lemon, clove, and eucalyptus. But the patient can choose whatever smell that they like. I know I would choose vanilla if I were doing it. So, but people need to choose smells that they like, and then they need to sit somewhere quietly. And it takes 2 or 3 minutes twice a day. You'll open the jar, hold it close to your nose, and you take gentle sniffs for about 20 seconds. And during this time, they want to really concentrate on the smell. What did lemon used to smell like? I'm thinking about the smell of lemon. And really focusing their thought on lemon, trying to block out any intrusive thoughts. Do this for about 20 seconds. Allow 20 seconds to clear things out, go on to the next smell. And they work through all 4, and it actually has pretty good success as far as helping people return to normal on their sense of smell. And then miracle fruit, I'd never heard of this before, and again, there's really no data on it. It's been studied with chemotherapy, but not for COVID-19. And it's basically a berry, and you can put the powder on your food, and it makes sour taste sweet. And it's really supposed to help with people who have COVID-related loss of taste or just differences in taste. It makes food taste a lot better. Then one last thing is return to play. And again, this is from this Journal of the American College of Cardiology. And they said, you sort of go, how sick was the patient if they were asymptomatic? They can return to exercise after 3 days of self-isolation. Obviously, you don't want to go out on the team until you've had the full 10 days, but they don't need to sit out for the entire 10 days. If they had mild or moderate non-cardiopulmonary symptoms, no chest pain, no shortness of breath, they can go back to training as soon as they have finished their self-isolation. If the infection was more than 3 months ago and no ongoing cardiopulmonary symptoms, they also can go back to play. If they get new cardiopulmonary symptoms, or if they have cardiopulmonary symptoms at the time you're evaluating them, or if they were hospitalized for possible cardiac involvement, or if they had PASC with cardiopulmonary symptoms, these people need the workup, the echocardiogram, the EKG, the troponin, cardiology consultation. If everything's normal, they can go back to play. If they have persistent or new onset cardiopulmonary symptoms, they need a cardiac MRI. And at this point, this is sort of beyond what I, as a primary care provider, am going to be doing. They're going to be managed by a cardiologist. They've got myocarditis. They need exercise abstinence for 3 to 6 months. And they may need more testing if this doesn't show what's going on. But that is all I had. Are there any questions?
Any questions or comments from the room? And we still have quite a crew on the video link. Anybody out there watching remotely have any questions?
It was either so brilliant I answered everything, or you're all fast asleep. So
No, it was that first slide, 0 to 80% that got it. What can you ask after that?
I know, I found that and I was just like, oh, why did I agree to do this topic?
Hi, Dr. Hayes. This is very good. It was a very good presentation.
Thank you.
I'm a pediatric nurse practitioner, and so I hear what you're saying from these studies, because basically kids come by with all kinds of symptoms. And in truth, what is the relationship to COVID? And what is, I think the most important thing I get from your talk is this really COVID long haul? Is this pandemic long haul? And so I really just appreciate it. I thought you did a great job. And you're right, I don't think the studies are out there yet. And
Yeah,
there's so much that goes on with children and the fact that their lives were so disrupted.
yeah. And like I said, if we find that 1% of kids are going to have lifelong symptoms, that's going to be a whole lot different. So, I'm hoping that we start to get studies at least saying, that the symptoms are, gone within 6 months, because those studies, if that was the case, we could do it, but just nobody has done that yet. So. But are you seeing many people who feel are pediatric long COVID? Because
Just from my colleagues.
yeah, I have seen a ton of long COVID in adults, but I have yet to have anything in kids who I definitely felt was long COVID. So.
All right, thank you very much.
Sure.
We gave you a tough topic.